Thank you everyone who's here at this moment, and hello to everyone who's going to be logging on later. To introduce the webinar, I have Ashley Bentley from the AAFP's Medical Education Division. You can take it away.
Thanks, Mackenzie, and thanks again for inviting the American Academy of Family Physicians to host some of the webinars for this week's National Primary Care Week. We're really excited about National Primary Care Week as we are every year, representing family physicians across the country who provide a lot of the primary care in this country. But we're especially excited about National Primary Care Week this year with some great topics. And I'm especially excited to introduce to you our two speakers this evening. So when the American Medical Student Association contacted us to try to find some speakers who could speak to rural health and also some of the technology issues that are changing the way that healthcare is delivered in rural settings, we immediately looked toward a few of our members who we know could speak not only to having practice experience in rural health and rural medicine, have not only taught residents and students, have not only done workforce research, have experience with technology, but also have been a part of national policy discussions and even international work in this area. So I don't expect our two speakers to be able to present on all of those topics tonight. They're going to give you some highlights of the things that they think you care about most as medical students, but certainly know that they have experience in all of those areas, and you'll be able to ask some questions toward the end. So keep your questions, whether they've addressed it or not, during the actual presentation. Send your questions in, and don't miss the chance to ask these guys about some of those areas of rural medicine. So our presenters tonight are Dr. David Schmitz and Dr. Eric Johnson, both with the University of North Dakota School of Medicine and Health Sciences, both from the Department of Family and Community Medicine there. Dr. David Schmitz recently made a location change to University of North Dakota, but he has more than 20 years of experience in rural practice in graduate medical education and undergraduate medical education, and is also highly involved with the AAFP, serving on the Commission on Quality and Practice, and with WONCA, which is the National Organization of Family Doctors. He serves as the North American representative to their group on rural practice. And Dr. Eric Johnson is an associate professor at the University of North Dakota. He's also assistant medical director of the Diabetes Center at Altru Health Systems. He is a graduate of the University of Nebraska Medical Center and did his residency in North Dakota at the program in Fargo there, and is board certified in family medicine, as is Dr. Schmitz. Dr. Schmitz, I'll turn it over to you.
Well, thank you, Ashley, and welcome to all of our students. It's very exciting to have a chance to speak, I think, about two topics that we were asked to be able to share with you tonight, and we're really looking forward to a bit of discussion as well. I will say that I'm very passionate about how medical students and residents and physicians and our healthcare teams can make a difference in rural America, and so happy to be speaking about rural medicine, but also at the same time talking about how the advent of technology now, especially in telehealth and telemedicine techniques, has really addressed some of the issues medical students might have around things like burnout, self-care, being able to provide care as a team, staying up to date, and providing the best access to medical care and, frankly, population health in rural America as close to home as possible. I really think that's what it's about, is having us be able to make a difference there. And so if we can just also allow Dr. Johnson to introduce himself, because when I was asked to talk a little bit about rural medicine, which we'll do in the end, I thought there's no one better than my colleague here at the University of North Dakota, who's really one of the national experts on one of the most important disease entities in the United States in recent years, and that is diabetes. So Eric, just let you introduce yourself with regard to telehealth, telemedicine, diabetes, and we're going to round this discussion out as we also accept your questions and really enter a discussion after a salient example of what we're doing here in rural North Dakota.
Thanks, Dr. Schmitz, and thank you, Ashley. I'm Dr. Eric Johnson. As noted, I am also here at the University of North Dakota School of Medicine and Health Sciences. I helped co-found a diabetes center program at a local health system here in 1998, and I've been the assistant medical director of that diabetes center program since that time. That makes up about 1/3 of my total schedule seeing diabetes patients. So just to get to the heart of the matter here, let's look over our objectives. We'll learn and discuss some basic telehealth concepts, rules, and regulations. We'll review and gain some understanding of the benefits of telehealth. We'll review and gain understanding of the limitations of telehealth. We're going to learn about rural telemedicine experiences here in North Dakota, and we'll discuss telemedicine specifically in the context of rural medicine. Although that's the biggest application here in North Dakota, telemedicine is certainly not limited to rural areas. Next slide, please. So where are we at? Well, we're at the University of North Dakota in Grand Forks, North Dakota. We're on the Minnesota border, and we're about 65 miles from Canada. Grand Forks is the third largest city with a population of about 63,000, and our mission is very rural and primary care focused. So Dr. Schmitz and I are definitely immersed in a very rural environment. Next slide, please. The U.S. primary care workforce right now is about 295,000 providers, and you can see a great preponderance of those are physicians. And this is data that comes from AHRQ. We also see that there are a fair number of nurse practitioners and physician assistants, and we find that many of our graduates work with these other professionals in those primary care rural environments. And I'll speak to that a little bit when I talk about some of the telemedicine services I deliver personally. Next slide, please. Healthcare professions in the U.S., this is a little bit of a busy table, but what I really want to show here is the percentages of different types of providers who practice in larger metro areas and smaller metro areas and then rural areas, and even what we might call rural, remote, or frontier areas. And you can see that primary care matches up much better with the general population numbers. About 80% of all people in the United States live in urban areas. And you can see that a good number of family physicians and internal medicine physicians and PAs and NPs do practice in these environments, whereas specialty care doesn't exactly always match up. And there's a lot of reasons for this. Some of it is technical. Some of it is that if I'm a nephrologist, I'm probably not going to be busy enough in a community of 10 or 20,000 people or smaller, and I need to find a way to expand the services that I'm going to provide and reach out to more patients. Next slide, please. This is the AAFP membership status of metro versus non-metro, and it really reflects these other data sets that I showed you. The membership has a very similar breakdown for those who live in metro areas and non-metropolitan areas. Next slide, please. So let's talk about some definitions. Telemedicine is a little bit more specific. This is the practice of medicine using technology to deliver care at a distance over a telecommunications infrastructure. In my particular case, we use a proprietary secure app, and this is between a patient, an originating spoke site, and a physician or other practitioner licensed to practice medicine at a hub site. So I deliver from the hub site, the patient is at the spoke site. Telehealth is a little bit broader collection of electronic and telecommunications technologies and services that support at-a-distance healthcare delivery and services. So this might support an education mission, for example. Dr. Schmitz and I often do statewide webcasts on a particular topic to reach a large number of providers. So that would fall under telehealth. Telemedicine does as well, but telemedicine, the phrase itself, is more specific about delivery of medical services. Next slide. There are really different types of telehealth delivery. We'll focus a little bit more on provider to patient, which looks a lot like a usual clinic visit. And then there's also something called e-visits, which are a little bit different. There's provider to provider, and that might be delivered through a mobile robot on site. An example that I can think of in our area is the Minnesota Telestroke Network, where a provider is brought into an emergency room setting via a robot, which is really a pretty cool system. It's often an iPad that's mounted on a movable stand, like a Segway almost, and they can bring the provider right into the room at the bedside. Then there are some others, like remote CHF or diabetes monitoring, and sometimes these involve a proprietary device. In a particular instance, in my practice for telemedicine, we do a lot of insulin pump and continuous glucose monitor patients. And those platforms can be sort of integrated into the healthcare record, and I can view that data sometimes on the website for the system itself or after it's been imported into an electronic health record system. So this is actually pretty cool, and our patients really like this. And we do have patients who live quite a distance from us, and they don't always need a provider visit, but they might need my input on what's happening with them with their diabetes technology, and I can do that as well.
And you know, Eric, the other thing, this is Dr. Schmitz, is that I think when we look at the cost savings and also the quality of life factors, I know some of the things that we've been looking at the National Rural Health Association is how we can work as teams to evolve not only the model of care, including open access to appointments with your family physician or provider when it's necessary. That can actually be triggered by a monitoring system for things like home glucose monitoring, which you mentioned, even a pulse oximetry check, whether or not someone's gotten out of bed at home. If they live alone, for example, there can be monitors that can be determinative of that, or even a laser trip, you know, not to literally trip, of course, but in the home to be able to show if someone's been in and out of the restroom. And so these various sorts of monitoring can keep someone perhaps at home longer, or at least in an assisted living environment, as opposed to extended care facility, nursing home type environment for longer. And the cost savings, quality of life, being in a rural environment, for example, around friends and family who can also be supportive, that level of independence can make a big difference. So telehealth is really a broad field that, again, could be coordinated to also allow access to care in a population-based model as opposed to you know, needing to even make a phone call or to drive into the physician office.
Dr. Schmitz, I'm really glad that you brought that up, because there are a couple of examples I can think of very specifically about that. There is a computer parts factory about 50 miles from Grand Forks, and the patients with diabetes who work for that company can get a monitor that will send data to a health coach. So it doesn't even have to be a physician service. And that's actually okay, because that probably keeps our days freer to do direct patient care in the clinic or in the hospital. And I'm finding that that system has really been of a great assistance to us. There are other ones like you talked about where the patient will get some kind of electronic message with a low blood sugar or some other things like that. So this is really important to understand that there's lots of different ways for this care to be accessed and delivered. Next slide, please. Telemedicine Rules, this is a document that we kind of have internally that really draws on a number of different documents. So the encounter occurs where the patient is located. So I'm in Grand Forks, but maybe I'll be seeing a diabetes patient at the clinic in Carrington, North Dakota. So the visit is actually recorded as a Carrington clinic visit. The provider must be licensed and follow the rules of the state where the patient is located. So let's imagine that maybe I'm going to see a patient across the river in Minnesota. I would have to be licensed in Minnesota to be able to do that. The provider must follow the credentialing rules of the patient site. So at the 3 different places where I deliver telemedicine service, I have to be credentialed at all 3 of those hospitals and clinics at those sites. We need to always remember HIPAA compliance. It needs to be private and secure. If I deliver a visit on my phone, I shouldn't be sitting in Starbucks while I do that. I need to be in a room with a closed door with nobody else there to assure privacy and to be HIPAA compliant. We want to provide the same quality as in a person encounter. And we've really had a big focus here lately at University of North Dakota on developing skill sets for telemedicine, because it's not just sitting there with the camera on you. And I'll talk a little bit more about this before we close. You need to document the encounter as a telemedicine encounter. This is not difficult. I create a chart note like I would in the clinic on the electronic health record, but at the top I need to note that it is a telemedicine visit. So I just add that as a smart phrase or however you want to do that with your record. And initial consults and encounters are allowed. So it doesn't have to be somebody that I've had a steady relationship and now I'm going to convert them to telemedicine visits. It can be a first-time visit. Sometimes for more complex patients, we require that they do come to Grand Forks for an in-person visit. But if they have a strong connection to a primary care provider at their site, we don't necessarily need to do that. And I've really built some strong relationships with the primary care providers at these more rural settings. Next slide, please. The AAFP has a telehealth policy, which I think is very sane and very helpful. And AAFP supports expanded use of telehealth and telemedicine as an appropriate and efficient means of improving health, which it certainly is. The treating physician really bears the responsibility for follow-up with the patient and the primary care physician. So I'll walk through what a visit looks like and how I communicate back to the originating provider. The AAFP also encourages states to engage in reciprocity compacts, which I think is very important. It's really difficult right now when you have to be licensed in every single state where you provide a service. And right now, that's the status. It would be great if you could have a more universal licensing system for telemedicine where if you had that certification, you would be more easily granted a license in the originating state where the patient is. And payment models should really support the patient's freedom of choice. The way it works here, a telemedicine visit actually bills out the same as a regular clinic visit. E-visits are a little bit different. E-visits are kind of like a video call to a provider that just take a few minutes. Those are often cash pay, but are sometimes covered by insurance. But a traditional telemedicine clinic visit, that usually bills out about the same. Next slide, please. The American Medical Association has an ethical practice document that includes issues surrounding telehealth and telemedicine. And the focus there is on fidelity, which has to do with conflict of interest or implicit bias toward a particular technology, competence in being able to deliver the care skills through a telemedicine system, transparency and informed consent. For example, I always start out by telling patients, this is not exactly the same as us being in the same room together. I'm not going to be able to do a detailed abdominal exam on you or a complete foot exam. I can do partial exams, and I can listen to your heart and lungs with an electronic stethoscope. But it's important for us to understand that there are some limitations to this, and I want the patients to get that they still need to be connected to their primary care provider at their site. Of course, we've already mentioned privacy and confidentiality, and we always want to be concerned about continuity of care. We don't want these to exist in a vacuum, and it's really important that we all stay connected and communicating.
And this is Dr. Schmitz. I'll just say Ashley had mentioned involvement in leadership and policy, and I think that's exactly it. Transparency, informed consent, and continuity of care. Family medicine is about relationships with your patients, with your community, and in the case of rural family medicine, these relationships are often very important with regard to not only the quality of care, but also just the experience of care. And so when we look at the use of telemedicine, I think that's been one of the biggest issues to make sure that we get right, is how do we form continuity of care amongst the providers who are providing these services?
Yeah, absolutely. And I work really hard to maintain those relationships. And I always copy the note back to the originating provider. I send them an internal message in the medical record if there's something that I need them to draw their attention to. Or, of course, I can just pick up the phone and call them, too, if it's really more urgent. So I'll talk about some of those issues when I talk about a typical visit. Thanks, Dr. Schmitz. Next slide, please. So this is what some telehealth platforms look like. The one on the left is on a tablet. That can be more like an e-visit. That can be a true telemedicine visit, but not typically. The typical telemedicine visit looks more like the middle picture, where I'm on a computer screen and the patient is seated there, and on site there's a nurse, a medical assistant, or in my case, sometimes a certified diabetes educator who's actually putting hands on the patient, like with an electronic stethoscope. They also help the patient connect a little bit more to the video. They stay in the room with them and they help them maybe if they have a hearing problem or they're just not feeling it when they first start with their very first visit. And then the picture to the far right is more the robot type of connection, like I talked about with the Minnesota Telestroke project. We're actually developing a curriculum piece right now in simulation where we actually use one of these robots and the specialist is brought into the emergency department to deliver care. Next slide, please. These are some other views of what else we might see with that. There is the patient who maybe has a specific monitor for a specific condition at home. We can also look at radiology profiles. At the hospital where I work here at Altru Health System, they do a lot of teledistance radiology with a group down in St. Paul, Minnesota. So if they have an urgent MRI, they have somebody on call immediately to read that. The e-visit is probably best illustrated on that smartphone picture. That's where the patient says, I have a sore throat and a fever. I need to talk to a doctor. And they can access a provider that way quite easily. And then there's other applications like we can see here with a military personnel where the medic on the ground is treating a casualty and they can be connected back. There's also some more global applications and other unique uses of different telehealth systems, but these are some of the more common ones that you may actually encounter during your education as a student or a resident, and you most certainly will.
And so when we look at some of the utilization of telehealth, this is Dr. Schmitz. I used to practice in a remote area of Idaho where the first responders from that local community might have a 45-minute ambulance ride just to the emergency room at our critical access hospital. They could at times transmit information about, for example, an EKG, so that I would know if I had to be prepared with special procedures or medications, or even sometimes, let's say, an airlift evacuation from that little rural facility to an urban center for cardiac catheterization, for example, versus not. So telemedicine has been going on, telehealth to a certain extent, for decades or more, but at the same time, even though we started telehealth with a telephone, now we've actually really begun to be able to look at how this can affect not only rural and remote access care here in America, but also internationally. A big part of that is broadband access to the internet and or cellular service, and with the advent of more frequent use of cellular service and cell phones, in addition to broadband, we really are seeing a transformation of access to quality access to care closer to home and in some of the most urgent situations. So to date, we certainly haven't seen telehealth deliver babies or put in a chest tube at a trauma incident, but we are seeing us be able to function as teams in a way that is smarter, more effective, and more efficient for our patients and our neighbors.
Yeah, it's great when we can push that care out to a provider in the field like an EMT. So thanks, Dr. Schmitz. Next slide, please. So my personal experience in telehealth starts back in December of 2013 when I started providing diabetes care from our diabetes center in a clinic visit setting to one site 150 miles away. The University of North Dakota does not have a university hospital or clinic system, so we are contracted to different hospitals around the state. And I'm contracted to the hospital and clinic here in Grand Forks that has the diabetes center that I helped found 20 years ago. Now I'm doing diabetes care for 3 different rural clinics. The closest is 100 miles away, and some of our patients live over 250 miles away. At the site in Rugby, North Dakota, which is 150 miles away from us, we have patients who live 100 miles on the other side of Rugby who come to Rugby to access telemedicine for diabetes care. And these are the 3 communities that I'm working with right now. Rugby and Carrington are fairly small, a few thousand people. Devil's Lake is a little larger by North Dakota standards. It has about 12,000 people, but they have a large center there that has lots of different telemedicine services. They have psychiatry, they have nephrology, they have pulmonology, they have cardiology, they have me doing diabetes delivery. They have a number of services at that more regional type of medical center. And I occasionally have students with me on site here, or sometimes they're at the rural site, and they will join the patient on the telemedicine visit so they can see how that works. Next slide, please. Altru Health System is the second largest system in North Dakota with the main campus here in Grand Forks, and we have satellites all over northeast North Dakota and northwest Minnesota, and that's where most of our telehealth is delivered. Our service area is about 250,000 people. Next slide, please. These are the telehealth specialties that our system offers right now. You can see on the map there of northwest Minnesota and northeast North Dakota. We've had a big push with mental health services recently. We actually have one of our psychiatrists who only does telemedicine all day long, 5 days a week. And we are also doing dialysis care at some sites where the nephrologist does all of this remotely. Dermatology is a recent addition for us, as is genetic counseling. Next slide, please. You can see that the patient location is pretty variable. It might even be in a skilled nursing facility or at home. And there's a small percentage that we aren't exactly sure where they're originating from with the e-visit. It's important for us on our end to make sure that we're in a private environment, but patients don't always do that. They sometimes will call in from the mall or someplace that maybe is less secure. And we always encourage them to move to a place that's a little bit more private. But primarily we're talking about hospital, clinic, nursing home, and maybe some residential. Next slide, please. The growth has been substantial. You can see when I started in 2013, there were not a huge number of visits, less than 200. And now we're getting into the thousands of visits every year. This has just been a remarkable piece for us. And this is visits of all type. This might be nurse originating, this might be remote monitoring, it might be the more classic clinic services like I'm delivering. There's really a number of different things here that we've already discussed that would fall under this header. Next slide, please. You can see that our top service lines by volume are across a wide variety of specialties. Right now, oncology is our #1 service provider for telehealth. And this is a lot of nurse-generated visits, but also patients who occasionally will get some treatment at their home site, which can be really important. In North Dakota, travel is not always ideal depending on weather, and the ability to deliver these services irrespective of other factors that maybe we can't control is really very important. And what we're finding is the primary care providers at these sites really feel supported this way. I think this is really important. Dr. Schmitz and I spend a lot of time trying to get physicians to stay in North Dakota and have their practices in both large and small communities. And in small communities, I think it's easy for a student to think, wow, I'm going to be here all by myself. This is really going to be difficult. But our primary care providers at remote small sites in rural North Dakota and rural Minnesota tell us that they really feel supported with this. And we haven't specifically studied it, but we suspect that it probably is helping with some burnout issues that providers might have otherwise, when they know that they can rely on that specialist to be available in relatively short order. Next slide, please. We also have a number of different pieces of equipment that we can use. We have ophthalmoscopes, we have otoscopes. The electronic stethoscope is actually very high quality. I actually prefer it to a regular stethoscope. There are things you can do with volume and equalization that might bring out different heart sounds that you might not be able to get otherwise. I recently heard a rumble very easily just by adjusting the equalization. So the quality of these pieces is very high. And of course, it's coming over a very dedicated, high-speed, secure internet connection. So the quality is terrific, as is the picture quality. Next slide, please. There have been some studies to show that there are improved outcomes with telehealth, including mortality, ER visits, things like this. This was a large study that is very well known that actually comes from the United Kingdom, where they are very embedded with telehealth across their country with specialists. And they've actually been able to show this very strong data with very good outcomes. Next slide, please. Locally, we have some outcomes data that I've collected from our diabetes service to the clinic in Rugby, North Dakota. We have a certified diabetes educator there who is very motivated and very data-driven, and she wanted to see were we actually changing outcomes. And as it turns out, we were. And we presented this data as a poster at the American Diabetes Association scientific sessions this year in San Diego, and also at the American Association of Diabetes Educators in Indianapolis. Next slide, please. So our methods were that we wanted to go back and look at patients who were enrolled in the telemedicine program. And the on-site certified diabetes educator coordinates all of these encounters. She does the scheduling, she gets everything set up for me, and then I'm on with them 2 half-days a month. And what we wanted to see were, did these patients have a reduction in their A1Cs pre and post use of the telemedicine service? Next slide, please. We found that they did indeed have a significant reduction in their A1C. Prior to contact, their A1Cs were about 8.7. At their last visit with me, their A1Cs on average were just over 7.5. So this was a pretty substantial reduction in A1C. And it's interesting, I thought at American Diabetes Association this year there would be lots of posters on telehealth and telemedicine. There's usually about 1,500 posters overall. We were one of 3 at that meeting presenting on telemedicine data, which really surprised me. But we were really pleased with our results, and we did get a lot of attention for this. Next slide, please. We also wanted to do a patient satisfaction survey with these patients, and we had nearly 100% return on this. And most of the patients agreed or strongly agreed with many of the parameters that we looked at, like convenience, not having to drive, etc. This was actually based on a patient satisfaction piece that this clinic was already using for all of their visits. The only concerns that we got back in some patient feedback was scheduling. I currently can only do 2 half-days with them. We estimate that I could probably do about 6 half-days a month with them to meet their volume. So we do have some scheduling issues, and that's a real limitation. I need to take care of patients in Grand Forks, too. So finding that balance is very important.
You know, and Dr. Johnson, this is Dr. Schmitz with just another example of patient satisfaction. I've done research looking at rural physician recruitment and physician satisfaction and retention in rural areas around the country. Interestingly, in my work in rural Utah, we found they were using rural telehealth with regard to patient counseling encounters. And in many of the states in the United States, access to mental health services, be it psychiatry or even counseling really, it can be a challenge. And so one of the things we found I found of interest, incidentally in this other research work, was how highly satisfied patients were receiving counseling services through televideo. And interestingly, as you can imagine, as a rural primary care provider, as a rural family physician, which I was in a town of 2,300, not 23,000, 2,302 for 6 years with 1 stoplight in the county, but it wasn't in my town. At that critical access hospital, if I handed a prescription, let's say, or a referral to go for counseling services, a lot of people might recognize your car in the parking lot. And again, I'm very thankful for hands-on relational counseling services with people in the same room, but it was interesting to see in areas where that wasn't as accessible, a person could walk into the front of a hospital and you could go left for, let's say, a lab draw to see what your potassium was or your A1C, and you could go to the right side into a room and receive telecounseling services, and nobody knew why your car was in the parking lot that day. So it's not a barrier for everyone, but it's very interesting how some of this dynamic change is allowing better and actually not only access to care, but perhaps improving patient satisfaction.
Certainly that's true. Thanks, Dr. Schmitz. We're also seeing here a big push within our medical school and within state government and our State Department of Health, particularly for telepsychiatry services. I think we're going to see a real boom with that in North Dakota. We're dealing with a significant opiate problem here, like lots of other places. I think telehealth is probably going to be one of the pieces for that solution, too. Next slide, please. So what else is happening in North Dakota? We're a very small state. We have about 700,000 people, and about 240,000 people live in the largest metro area of Fargo, North Dakota, and Moorhead, Minnesota. We do have a Department of Education Resources grant right now under Dr. Richard Van Eck, where we're working on a simulator robot type of telemedicine learning piece, which I think is really interesting, and that's very interprofessionally oriented. So we'll see what that looks like when it's all complete. I just said there's an emphasis on delivering mental health care statewide. There are lots of different players here involved and all working very well together. And I think in the next 2 to 5 years, we're really going to see some substantial changes with that. We're also developing a telehealth skills teaching module in conjunction with the College of Nursing and Professional Disciplines. It's really important that you have skills to do this properly. You just can't sit at a desk with a computer on you and have a patient on the other end all by themselves in a room with a camera on them and hope that somehow you connect. It takes a lot more than that, and we really need to work on skills to help people be good at this and feel successful with it. Next slide, please. Skills are very important to engage the patient, and it's not exactly the same as a regular clinic visit, but there are some things that I learned in broadcasting school 35 years ago that really helped me today with this. You want to sit up straight. Remember that to have eye contact with the patient, you need to look into the camera, not look at the patient's picture on the screen. If you're looking at their picture on the screen, it looks like you're looking down. You also want to be able to project your voice through the microphone. You have to remember that you're speaking to a microphone, and that needs to project to the patient. So you want to speak up, you want to have good enunciation, and you want to make sure that the patient can hear well and understand what you're saying. And we can modify some of those things to help patients maybe who are hearing impaired. And I encounter that quite a bit with many of the older patients. And you want to kind of act like you're in the room with them. You don't want to be dinking around on your smartphone, drinking or eating, have an apparent lack of focus. If you lean back in your chair and look away, that really sends a message to the patient that you're not really engaged. So you really need to be involved with the camera and the microphone during the entire visit. And we're working on some modules to help people learn those types of skills. Next slide, please. So our summary on telehealth is that it's very likely that you'll do some kind of electronic care delivery or education. My experience with telehealth is that it really supports rural face-to-face care delivery. And we're actually looking at this as a recruiting tool for our healthcare system. We want to say to potential primary care providers in rural clinics, here's what we can support you with, and your patients will have ready access to these specialties. Knowing your state's rules is very important. Fortunately, health systems that do a lot of telemedicine are generally very good at this, and you want to take opportunities to learn more in various settings. As Dr. Schmitz and I have emphasized, there's lots of different ways to deliver care with telehealth systems. Next slide, please.
And so this is Dr. Schmitz, and thank you, Dr. Johnson, really a national expert on both telehealth and diabetes care, and so what a great opportunity to be really talking about both and some of the evidence that you've been able to also submit. And I wanted to just emphasize that telemedicine is augmenting the need for physicians and what our experience is not only in caring for individual patients, but caring for communities of patients, population health, and also in caring for ourselves. It's not replacing the need for family physicians in rural or for our providers, but it's really, in a sense, allowing us to operate within teams that extend across time and distance in a way that we didn't before. I'll give you a couple of examples. I mentioned that I've done workforce recruitment looking at recruiting family physicians to critical access rural hospitals, also rural health clinics and rural federally qualified health centers or community health centers. And in those situations, we found instances, for example, where physicians are able to, I'll just give you an example, be able to hit a button on the wall in the ER and not be alone anymore. You know, one of the stress points for rural practice can be the emergency department. Even if there's not a high volume, sometimes there can be a very high acuity. And so to be able to have your nurse by your side, perhaps a colleague, being able to take care of one or even multiple patients in a given situation and not have to be manning a clipboard or whatnot or an EMR to enter when that last dose of epinephrine was given or atropine or whatever is going on, and also to have someone who is able to offer advice per se. But actually, when I was talking to a very experienced, very rural provider, and this was several years ago, but it was in rural North Dakota, he told me, he said, you know, it wasn't the advice I got with regard to giving the care. I was competent and ready to give the care. He said it was the experience I had when I went home, because some people in that, there was a couple of people involved in that emergency room interaction, and some were able to survive and a couple did not. And my point is that he was able to share the fact that by being told, you know what, you did everything that could be done, you did a very good job, and it allowed him to really have not only the competence but the confidence around knowing that the best care was provided, whether it was in that rural remote setting or frankly in another urban center. And so I think that that allows us to avoid some of the isolation, social isolation, that can otherwise be perceived or be real around providing care in limited resource environments. So I think that this is just one example, again, of looking at this as a recruitment benefit and of really being a supportive part of the team. Because one thing I'll tell you from my 6 years in rural experience in a very small town, and sometimes it would snow and it would be foggy and you might or might not be able to get the helicopter in, and sometimes babies come early. So whether or not your hospital says they deliver OB, sometimes you're going to deliver OB because that sort of care is what's needed. And so as we as family physicians, as rural providers, really give to patients the best access to quality care as close to home as possible, we're going to do it in a team. And so I think that telemedicine, telehealth is just one example of how technology is improving that, in addition to what really does matter, which is teams of people caring for each other in professional and quality ways. And so I just wanted to stress that point because I've seen it, I've lived it in some of the 10 states that we've been doing research, and frankly, the 2 states that I've been practicing in over the last 25 years of my career. So when we take a look at telemedicine, it's enhancing both care and education of ourselves and of our patients, but I think as providers, it's actually allowing us to do more. Another example that we're instituting here in North Dakota around the opioid issue is something known as Project ECHO. You could look into more with regard to what Project ECHO has done, but it allows case-based sharing of difficult subspecialty type areas of medicine to enhance primary care, family physician provider access to providing care. Back in the 90s and 2000s, it was around hepatitis C, and it was developed at the University of New Mexico to allow rural patients to receive care for hepatitis C by primary care providers. And today we're going to be using this for the first time in North Dakota this year to look at medication-assisted therapy for opioid dependence disorder and what we can do to support this important issue in our own state. So what does that mean for the University of North Dakota, for Dr. Johnson and I? What does it mean for you as medical students as you choose your specialty, as you choose where you'll be practicing, rural or urban or otherwise, and particularly if you're in a resource-limited environment, as I like to say, or an underserved area? It means you're going to need education that is future-focused and allows you to participate in team-based care, which includes telehealth and telemedicine. That's how we will be able to deliver the best quality care to folks, in addition to making sure that we're making as much of an impact as we can as one member of the healthcare team as physicians and as primary care physicians most often in rural environments. Next slide, please. So how can we get you connected? How can we also keep you involved? I just put up a couple of different websites that you could be able to refer to, but one is the American Academy of Family Physicians Member Interest Group on Rural Health, where you'll find these discussions about everything from scope of practice to what do rural family physicians really do, what's their life really like, how can I get more experiences in rural, and how can we see how telehealth is affecting rural. Another is the National Rural Health Association, which really is able to look interprofessionally and really look at a broader lens with regard to what we're seeing for different types of delivery across everything from critical access hospitals and their importance to some of the most very remote aspects of delivering health care here in the United States. WONCA is the International Association of Family Physicians and General Practitioners across the globe, and Rural WONCA actually has an opportunity to host a resource webpage, which we actually help to host right here at the University of North Dakota. And so you can get more information on international conferences, interacting with colleagues, and a new medical student group called Rural Seeds that actually hosts, using technology, a rural cafe to talk about some of the issues in rural medicine. So you're going to find actually in the National Rural Health Association a specific student group, as well as with Rural WONCA internationally, and most of those are done in English, so very accessible to you all. The RTT Collaborative looks at not only rural training tracks and residency education, which allows students and then subsequently residents to participate more in training in rural places, but it also has broadened itself with regard to its mission, and you'll find specifically medical student resources around, again, answering some questions about what's it like to be in rural, what's it not only like to practice in rural, but what's it like to train in rural places. Some of our research has shown over the years that training in the sticks, if you like. So it actually shows that the more time you spend in rural, the more likely you are to spend in rural. We think in part because you'll not only find it to be enjoyable, but you'll also find it to be doable, and it'll actually allow you to use many of your skills that you're developing as students and residents in practice and as a lifelong learner, but also as a lifelong server. And so I think that's one of the most rewarding parts of my job and career, is knowing that when I get up in the morning, and that's occasionally still in the middle of the night if my pager goes off, that I can make a difference that day. And then Rural Prep is a new opportunity looking at research, looking at some of the best practices in medical education. The reason I give you that website and I'm involved in that project is because there are opportunities in the future, over the 5 years of this grant, federally funded, to look into micro-research grants around answering questions around medical education for rural practice, and also looking at some of the opportunities for medical students and others to present some of their work around research in rural medical education. Next slide, please. Eric's got a couple of other resources and credits to give, and I'll let you talk about that.
Yeah, certainly. The AAFP Telemedicine and Telehealth Resources page is a great one. There's also a couple of resource-centered listings that I've got here for you, and those links will take you to important resources about the changing landscape of telehealth, and also to kind of keep up with some of the regulatory types of things that go with it. Next slide, please. I'd like to acknowledge Jessica Pacino, who's our telemedicine coordinator at Altru Health System, and Marcia Wayne, who's our telehealth manager at Altru Health System. These two are what makes it work. These are the ones who are responsible for all the success that we have seen. And if you want to contact me, you certainly can by email or calling me here at this number at the University of North Dakota. I would be happy to share any information with you that you might want. Next slide, please.
And so as we wrap up, again, this is Dr. David Schmitz. I'm currently the president of the National Rural Health Association, very involved with the American Academy of Family Physicians. Happy to be contacted as well through any of those, as well as the University of North Dakota School of Medicine and Health Sciences. We'd love to take some of your questions now, And for those who are watching on a recording, again, be able to have you interact with many of the rural physicians who are in rural America, because through many of the organizations and opportunities we've discussed, it's your energy, it's your desire to be able to make a difference for our patients, who are often our friends and neighbors in rural places, even sometimes family members of ours, who we can then begin to have, again, increased quality access to care as close to home as possible, whether that be rural or urban, with each of you making a difference on the team. So thank you, Ashley. We'll turn it back to you for any questions and wrap up.
Mackenzie, are we able to receive any questions?
Yes, if anybody has questions, feel free to put them in the chat, and I will make sure that we can all see those. I guess in the meantime, I have a question. So we've talked a little bit about telemedicine in regards to people who don't necessarily have access to care. Have you noticed at all that there's a specific crowd that's using telemedicine? I'm thinking, you know, my generation and younger, people who are really screen positive, right? So that we want to be behind screens and do everything via our cell phones. Is there a certain crowd, like the younger crowd, that would prefer telemedicine even if they had like physical access to care? Have you noticed any trends in that?
This is Dr. Johnson. That's a great question. I have noticed some trends with this. I have a large number of type 1s in northwest North Dakota who it's more convenient for them to go to Rugby to get care, but they really like the telemedicine aspect of it. And they especially like being able to share values like on their continuous glucose monitor with me electronically without having to necessarily have a visit. There's lots of different ways that we can use their technology to maximize their care. Having said that, North Dakota is a state with a very large elderly population, and I'm not really seeing any issues with elderly people in telemedicine visits. It's very rare that I would see somebody whose hearing is so impaired that they just can't do this. That would be kind of unusual. And I have a lot of diabetes patients extending into their 60s and 70s now who this is their preferred method. Even if they have a reason to come to Grand Forks for something else, they would prefer these electronic visits. So it's a little of both, but definitely with the young type 1s in rural environments, this is a great way for them to get care, and they really like it. Young adult type 1s are sick of talking about diabetes, but they never get tired of talking about technology. And we're really able to exploit that really well, I think, with that population.
Mackenzie, this is Ashley. I'm curious if Dr. Schmitz and Dr. Johnson would each share a little bit about just being a rural practitioner. How would a medical student know if they have what it takes to be in rural primary care?
I think that's a great question, Ashley. I can tell you for myself, I actually grew up in New York State, but I was mentored by a family physician who told me, you know, I know you've got some school loans. I know that you are looking into rural family medicine. But you know what? You're still going to have one of the nicest pickup trucks in town. And he was right. And I think that was one of the things. I had a heart for it, Ashley, and I still do. And so I know one of the things was just having an opportunity to be mentored, have an opportunity to get some experiences is really important. To be in a rural place, it really lowers some of the barriers, I think, around concerns. Like I said, everything from a lot of myths out there with regard to how many Christmases out of 4 am I going to be on call, or what's it going to be like to be on call, how frequently, and can I keep my skill set up, and some of these different things that you find are questions really can be answered by being there and seeing how it works. And not only that, but I think especially for some of my family medicine residents, answering the question that allows us to say, if it wasn't for me being there, how would this have turned out, or who would have been better prepared? Many times, especially now that we're no longer isolated in maybe ways in which we were when I was first going into practice nearly 20 years ago, there's an opportunity to know that you're making a difference every time you are. There's an opportunity to be able to be off from work and have a life balance in a sense that allows us to know that we're part of the team, but we're not there alone. So I think that in many ways, the spirit of it is the same. The difference we can make is the same, but there have been a lot of advancements, and we're seeing a lot of people come into rural practice who have a couple of expansions to their family, become part-time for a while, come back to full-time, and the opportunities to be able to do that essentially in almost any part of the country to our satisfaction of our careers and to the satisfaction of our communities and patients has really expanded.
Yeah, I think that's right. I personally never worked in a really small town, although I did have training in small towns. When I went to the University of Nebraska for medical school, like lots of places in the upper Midwest, we were required to spend time in rural communities. And some life circumstances led me to a career in diabetes. I got type 1 diabetes as an adult. And at that point, I felt like I wanted to be able to assist rural providers to deliver high-quality diabetes care. And I got very involved with the American Diabetes Association. I'm currently on the primary care advisory group for them. And it's really my mission to help deliver quality diabetes care and content to providers so that they can deliver guideline-based care. We do have a question, one from Alaska. Spent a lot of time in remote and rural settings, I'll bet, similar to what we do. Have you found that recruiting mid-level providers from a community is an effective way to keep them in practice longer? My observation with that through telemedicine is yes. Places that have really strong team-based care with a variety of providers, everybody seems to be a lot happier. What do you see, Dr. Schmitz?
Again, I spent a month in Nome, Alaska, and used to do radio traffic by shortwave radio or telephone, as the case may be, and working with village health aides all the way to our physician assistant and nurse practitioner colleagues has really been part of that team-based care. I'll pick up number 3, too. Did you mention veterans care in rural? I will say that we're seeing outpatient veterans care being collaborative with other settings in the CBOC setting, and use of telehealth, including teleradiology, has really expanded care to our veterans, many of whom are located in rural America.
And have difficulty traveling.
Exactly.
Certainly. And then there was a question about the experience with the community health aid model, focusing on recruiting individuals from the rural community to be the provider on the ground to guide the telemedicine consult. My experience is that what happens in a rural community is you get, in my particular circumstance with diabetes care delivery, we get a certified diabetes educator or a nurse in the health system at the rural site who really seems to be engaged and involved with this process, and actually works with the rural clinic to get patients into the system for telemedicine visits. And this is somebody who's usually really connected to the community and often is seeing patients around their town, in the grocery store, at the football game, and is always kind of seems to be working it. And when I work with somebody like that, I know that this is somebody who's really connected and is working hard as a provider to get patients into the clinic.
And Dr. Johnson, maybe that's a good place to wrap up. And so on behalf of the two of us, please let me just say, remember to look with a rural lens towards rural health care. Remember to be part of the solution, but don't bypass what goes on in rural communities. They're self-empowered to be able to be some of their best advocates, as are your patients, friends, and neighbors. Thank you, Ashley. We'll turn it back to you.
Thank you, Dr. Schmitz and Dr. Johnson. We really appreciate you also sharing contact information and being willing to connect with students who are more interested in learning more about